All right, so we're going to talk about ostomy care, just ostomy 101 to get started. General rules of thumb for ostomy care is we're changing this pouching system, everything, the barrier, the pouch, twice a week. That's the goal. Every 3 days, we take everything off. We're cleaning the peristomal skin. What are we cleaning the peristomal skin with? We're cleaning it with warm water and a washcloth. That is it. So some people say, oh, saline. Nothing's wrong with using saline, but we don't want the patient to think that they have to use saline when they get home, right? We don't want to put like a Dove liquid soap. We don't want to use wipes of any kind. No wipes, no baby wipes. Sometimes they'll bring them, the patient will bring them with them, the baby wipes, because it's intuitive, very easy to clean up. But what happens? They leave oils and lotions on the skin, and then nothing sticks to the skin. These barriers that you have are designed to stick to clean, dry skin with nothing on the skin. So the next step, and to hopefully help prevent or cut down on leakage, is we're assessing the skin. Does everything look good? If everything looks healthy, we're ready to measure the stoma and put the pouching system on. So when we measure the stoma, we're going to measure to the size of the stoma. We don't want any healthy skin exposed, right? No more, they say, than 1/8 of an inch larger than the stoma hole, right? We want to protect the skin. We know what happens when stool or urine gets on the skin. It starts breaking down, and when it starts breaking down, it's really hard to get something to stick to the skin. So measuring properly is key. I always ask one trick question of, when you're measuring and applying a pouch, what position do you want the patient in? Do you, and most people say, supine position, laying flat. But I look really good laying flat, right? You put a barrier on me and you sit me up, I have rolls, creases, wrinkles, whatever it is. So you want that patient, ideally, if they're able to, sitting up, standing up when you place that pouch on them. You can pull them up underneath the breast to kind of even the skin out, and then you place that wafer down. But again, if you're laying super flat, everybody looks really good, you sit them up, things change. So getting a good measurement on the stoma is super important. And then you take your wafer. There is a grid on the back, so you can cut, if it says 30 millimeters, you can cut to 30 millimeters. You can trace the hole that you measured on the back, and then you go ahead and you cut your stoma hole. You can see here I already put the barrier down, but just for practice here, I'm gonna say I think this is 30 millimeters. We're going to cut our stoma hole out. And we're going to make sure this, a little bigger, so a 30. So it's always good to start smaller and work our way to the bigger. If you cut this hole too big in the barrier, you're throwing it away and getting another one. There's no patching if you've cut this stoma hole too big. Again, if stool or urine gets on the skin, nothing fits. So you want it to fit to the size of the stoma. You take the backing off and you place this down on the skin. You'll notice there's a felted tab. This is oval shape. There's a felted tab at the top. That's normally facing north towards the head because the patient can find that to remove it very easily. So you can see here, my barrier is down. You have a two-piece system here. So it's a barrier and a pouch that go together. You cannot just stick this adhesive pouch on the skin. You need a barrier to protect the skin. So this is down. That we have a floating flange here where you can get your fingers underneath the part that doesn't stick to the skin. That's what we're applying the pouch to. There's a blue circle, that's your bullseye. So the way I like to apply the pouch is you take the paper off the back of the pouch to expose the white adhesive. This white adhesive, again, is fitting in the middle of that blue circle. The way I like to teach it, from a nurse's perspective, you're coming at me this way, right? If you pull up the tail of the pouch to expose the white adhesive at the bottom, and you find where the white hits the blue on the pouch, on the barrier, and you let this fall into place, it knows where to go. Okay, but it is an adhesive coupling. We need to seal it. So for a lack of a better term, I say get your pinchers out, go underneath, and you seal it all the way around. And then you show it some love. All ostomy appliances do need a little love. That's what allows this to adhere to the skin, a little heat and a little pressure. So if your patient's able to hold on to it, we don't want to put a brand new pouch on the patient and send them out the door. It needs a little bit of time to warm up to melt the skin. You notice I didn't put skin prep down on the skin. I didn't put powder on the skin. If the skin is healthy, we are putting this barrier directly on the skin. It is designed to stick to skin. Now, patient comes in, the the skin is wet and weepy, it's broken down, they weren't caring for it at home. That is when we're using warm water, a washcloth. If you need to use some sort of soap, a liquid dial soap, but nothing with oils and lotions. Again, warm water is really all you need to clean the skin, dry it nicely. Skin's wet and weepy, what are we doing? We're gonna get our ostomy powder, which you do have in your clean utility closet, and whatever barrier you have. You have, I believe, a Smith & Nephew spray barrier back there. What gets, people get confused of what goes first. So hopefully I'll be able to make this make sense. You want to put powder on the skin first, not the barrier. If you put a barrier down and you spray that all over the skin, then put powder on top, the powder doesn't get to the skin, right? And we're working with wet, weepy skin. We don't want to lock that in. So we're going to put powder on the skin first. This is called crusting. This is your catch-all for most ostomy skin irritation. You put powder on the skin first. You brush off the excess because we don't want it to get clumpy. You take your spray barrier and you lock it in. Think of it as makeup. You put powder on your face, you lock it in with a barrier. So then you take your, whether you have a barrier pad wipe or you have the spray, and you set that powder in. You allow that to dry, okay? You put a little bit more powder. This is why we call it crusting. Put a little more powder, brush off the excess, set it in with your spray or your wipe, allow it to dry. It's always powder first, then it's prep, okay? It'll start feeling a little sandpapery. I would probably do it 3 times in the area that you need it. Brush off the excess, set it in with your skin prep or spray, allow it to dry. Then you can pouch over that, because it's really hard to put something adhesive on wet, weepy skin, right? So we want to do that crusting technique. Powder first, then prep, super important. The other thing to cut down on leaks is to cut that stoma hole to the size of the stoma. If you cut this too big, you get another barrier. You must cut it to the size of the stoma. If not, the stool or urine is going to get underneath, undermine, and then nothing's going to stick to the skin. We want to get ahead of that. So that is how you properly apply an ostomy appliance. Show it some love, nothing on the skin, nothing with lotions and oils, and always showing it some love. Now, emptying the appliance, do you want me to go through the emptying? We want to empty when it's no more than a third full. If it gets too full, it gets too heavy, and then nothing, and then it pulls away from the skin, right? And I'm not going to say this is going to fall on the ground, but it's going to pull away from the skin where stool or urine can get underneath. So you have a little all Velcro tabs here, and you roll it down nice and slow. When you get to the bottom, there's this little flap at the bottom of the pouch, and we don't want stool to run over that. We don't want to put our fingers up here to empty it. So we designed it with 2 Velcro tabs on the back of the pouch. Those are to open the pouch, not close it, which is not intuitive because you think of Velcro as closing something. Fold it back on itself, pinch, it opens really easily. Then that Velcro's not exposed to the stool. Wipe it clean, flush it away, that's all you do. Release that Velcro tab, roll it up towards the patient's head. You know you're doing it right when you see, hopefully you can see this, headlights. You'll see some taillights. You'll see a bumper, and you close the doors. Just roll it up towards the patient's head. The Velcro connection's at the end, and you can tuck it up under the plastic if you like. And you're on. And that's it.